All right, guys, we're going to get started here in about 3 minutes, so just hang in there. For those of you who are already on the call, there are handouts. If you go up to the top of your OmniJoin screen next to attendees and chats, in the handout section, there are 3 handouts there if you didn't get them in your email yesterday. And then since everyone is on mute, we will be doing all questions through the chat box, and then I'll ask them to Debbie or answer them as we can. Thank you. All right, guys, it's 10 o'clock. Everybody able to hear? Had a couple messages that people weren't able to hear, so it sounds like everything is going well. So I'm going to go ahead and get started. I want to welcome you to our webinar this morning on the MDS changes that are going into effect on October 1st. And just so you guys are aware, presentation will be recorded for later viewing for people. If you can see up on the left-hand side of our meeting, there is the chat box. I currently have everyone on mute except for Debbie and myself. And so any questions that you have, feel free to type them in the chat box, and I will pass them on to Debbie as time allows in her presentation. This is being recorded, I think I said that already, and there are handouts next to the chat box. If you click on that, there are 3 handouts there with the PowerPoint and the 2 other sheets I'm going to be talking about, just in case you didn't get them for your training. So let's go ahead and center ourselves, and we'll start out with a prayer. Holy and triune God, you inspire and support the common life. Generously, you gave St. Bernard many talents, leader, preacher, peacemaker. Grant us the grace to share one of our talents today. Open our hearts to your spirit of love through Christ our Lord. Amen. All right, I want to thank Debbie Bennett for coming in and helping us out with some presentations on what's going to be changing coming up for the MDS. So at this point, I'm going to go ahead and turn it over to her.
All right, thanks, Stephanie. So as Stephanie mentioned, this is all about the REI changes that will go into effect on 10/1, and it is regarding Section GG. The new Part A PPS discharge assessment, there was much talk about the Section GG, but not too much about the Part A PPS discharge assessment. Also, some updates on quality measures, and a few changes in Section J and M that we'll discuss. what does it look like, and what do we expect? So first of all, this is all being driven from the IMPACT Act, and I'm sure many of you have heard about the IMPACT Act. And this portion, it's requiring that CMS implement cross-setting quality measures. Okay, so that way it's standardized patient assessment data that can be used across all types of post-acute care settings, which can include long-term care hospitals, inpatient rehab facilities, home health agencies, and obviously nursing homes. So why are they doing this? To help with quality care and improved outcomes, data element uniformity, comparison of quality and data across those post-acute care settings, improved person-centered, goal-driven discharge planning, and exchangeability of data. And that's a big part of this as to why they kind of went to Section GG, especially. So that way, when comparing to different settings, where our data is being compared apples to apples instead of apples to oranges, okay? And then obviously coordinated care. So there are two major changes to the MDS. And I talked about the quality measures and a few changes to Section J and M. They're pretty minor, so I really want to pay attention to the two major changes, especially that's going to impact you. Okay? And that is the Part A PPS discharge assessment and Section GG. So the Part A PPS discharge assessment, okay, it's a reason for discharge assessment that was developed to inform current and future SNF QRP measures, okay, and for the calculation of these measures. It consists of demographic, administrative, and clinical items. This Part A PPS discharge assessment, it will not affect billing cycle. So that's important to understand. It is for traditional Medicare Part A only. So it does not include your Medicare Advantage plans, any possible private insurance plans, etc. So when is it going to be needed to be completed? Well, you're going to have to complete a Part A PPS discharge assessment for planned discharges. So when you mark A310G as a 1, meaning that it's a planned discharge, okay, and the resident was Medicare Part A, it's going to trigger now you're going to mark A310H. Is this a Part A PPS discharge assessment? And it will be marked as a yes. Okay, so you're going to be doing this when a resident's Medicare Part A stay ends, but they physically remain in the facility, or there's a different option too here, because you can combine an OBRA discharge and a Part A PPS discharge assessment. When you're talking, well, I thought they had to remain in a facility. Well, this is if a Part A PPS discharge assessment can be combined with the OBRA discharge assessment, meaning the discharge date A2000 on a planned discharge that occurs on the day of or one day after the end date of the most recent Medicare stay. So you take them off of Medicare and they discharge, or you take them off today and they discharge tomorrow. That's what this scenario is talking about, where you can combine this Part A PPS discharge assessment with the OBRA discharge assessment. So your coding rules is that it must be completed when Medicare Part A stay ends, but they remain in the facility. Again, planned discharge. ARD is A2300, for a standalone Part A PPS discharge assessment is always equal to the end date of the most recent Medicare stay. Your ARD may be coded anytime during the assessment completion period, of which that follows kind of the same guidelines as all of your PPS assessments, is that kind of goes by the ARD plus 14 calendar days. So whatever date you put in the end date of the most recent Medicare stay, you have 14 calendar days to complete it. Therefore, you also have that amount of time to input your ARD. Medicare Part A stay ends and the resident is physically discharged from the facility, and OBRA discharge assessment is required. So again, you took them off, okay? So your end date of the most recent Medicare stay occurs on the day of or one day before the discharge date of a planned discharge. So your OBRA discharge assessment and a Part A PPS discharge assessment are both required, and they may be combined. So when you combine them, the ARD must now be equal to the discharge date. Because remember, for a OBRA discharge assessment, your ARD must be the date that they leave the facility. But if you are doing a standalone Part A PPS discharge assessment, then the ARD needs to be the last covered day. Okay, so there's that difference. A Part A PPS discharge assessment may be combined with most PPS and OBRA required assessments. Again, just like with combining any assessments, all requirements for those assessments must be met. So you have to follow the most stringent one. It must be completed within 14 days after the end date of the most recent Medicare stay, and it must be submitted within 14 days after the MDS completion date. If the resident's Medicare Part A stay ends and subsequently returns to a skilled level of care and Medicare Part A benefits resume, the Medicare schedule starts again with a 5-day PPS assessment. Before we move on to the other next slides, there was a question yesterday regarding exhausting benefits. Do you have to do one of these SNF PPS discharge assessments? And all the information that I can find is that yes, you would be required to do one because it is based off of, it's a planned discharge from Part A. So even though they exhaust, but it's a planned discharge from Part A. And they're going to remain in your facility. So a Part A PPS discharge assessment and OMRA impact. So how are they going to be impacted? So you have a start of therapy plus a Part A PPS discharge assessment. So your ARD must equal the last day of a Medicare Part A, and the last day of the Medicare Part A stay must fall within 5 to 7 days after the start of therapy. The ARD must be set by no more than 2 days after the date of discharge. And why is that? Because it's following the flex day rules for the start of therapy, right? Date of discharge must also be equal to the ARD and the last day of the Medicare Part A stay. And again, it must be completed within 14 days after the ARD. So an end of therapy plus a Part A PPS discharge assessment. So you have the ARD must equal the last day of Medicare Part A stay, and the last day of the Medicare Part A stay must fall within 1 to 3 days after last treatment day. Again, the ARD must be set no more than 2 days after the date of discharge, following those flex day rules. Date of discharge must also be equal to the ARD and the last day of the Medicare Part A stay. And have to complete within 14 days after the ARD. A COT plus a Part A PPS discharge assessment. So if a Medicare Part A stay is on day 7 of the COT observation period, then a COT is required and it must be combined with a Part A PPS discharge assessment if the COT is needed. Okay? ARD must equal last day of Medicare Part A stay, and both a 2300 and a 2400C must be on day 7 of a COT 7-day observation period. Again, you have that 2 flex day rule following the COT. Okay, so your ARD must be set by no more than 2 days after the date of discharge. Date of discharge must also be equal to the ARD in the last day of the Medicare Part A stay. And again, same completion time frame, 14 days after the ARD. So here's just a little bit of a quiz that you can just do amongst yourself or yourselves if you're there with a group, just to kind of give you some examples. So what would you schedule and what would be the ARD? So first of all, you have to do a Medicare Part A PPS discharge assessment, right? Because you took them off on 10/4 and they stayed in your building. They went on to public aid, Medicaid, whatever you would like to call it, right? What's going to be your ARD? Your ARD must be 10/4, okay, because it must equal the date of discharge from Part A. What would you schedule and what would be the ARD for this situation? So in this situation, they're discharging home the day after their last covered day. So you have 2 scenarios that you possibly could do. You can do a standalone Part A PPS discharge assessment with an ARD of 10/4. So you could do that. Then on 10/5, you can do a OBRA discharge assessment with an ARD of 10/5. So you can do 2 separate discharges, or you can combine your Medicare Part A PPS discharge assessment combined with an OBRA discharge assessment with an ARD of 10/5. Now, I can tell you what I would probably do, but to each their own. Those are your possibilities that you could do. What about this situation? Now we're looking at not just the discharge, but what other situation is going on? Yeah, where they've refused, they've missed 3 treatment days of therapy, right? And then they discharge out to the hospital. So first of all, do you have to do a Medicare Part A PPS discharge assessment? No, because they discharged out to the hospital. It was an unplanned discharge. Because remember, these are only for planned discharges. So now you just want to look, do you want to do an end of therapy or not? Okay, and I would not want you to, okay, because they discharge on that 3rd day. So you don't need to do an end of therapy. What about this situation? How come my one slides are not advancing? I am so sorry. They're advancing on my one screen and I look over to my other one and they are not. I will back that up just a little bit so you can kind of get an idea of what I was referring to with the end of therapy and discharging to the hospital. All right, so now this new situation, now what would you do? So now you got to think to yourself, what else is going on? Okay, they discharge out to the hospital. So what first should be your thought? Oh, I do not need to do a Medicare Part A PPS discharge assessment because it's an on-planned discharge. But what else now should be popping into your head? Is a COT needed? Okay, because they had an RVA, and now 7 days is when they went out to the hospital. So do you have to do your OBRA discharge assessment on 10/8, but would you want to combine it with the COT or not? Okay, and that's where strategy kind of comes into play, because they were an RVA. If you can do the math, they're going to be into an ultra high on that 7th day of that COT observation period. So I'd probably want to combine that. Making sure my screens advance at the same time. So what about this situation? So now their last covered day is 10/8. Last covered day, not a discharge from the facility, right? So we took them off of Medicare. So what's your first thing you're going to know that you need? You know that you're going to have to do a Medicare Part A PPS discharge assessment with an ARD of 10/8. But again, this is on that 7th day of your COT observation period that this occurs. So now you got to know that, oh, do I need to do a COT or not? And in this situation, they were an RUA on the 5-day. 7 days later, what's happening? They're decreasing in intensity. So now I'm going to be down to a very high. So a COT is required. So you'd have a COT combined with a Medicare Part A PPS discharge assessment with an ARD of 10/8. Now, what would you want to be talking with therapy about? Well, you want to be anticipating this, right? And hopefully this would not occur. All right. So, Stephanie, are there any questions posted regarding the Medicare Part A PPS discharge assessment?
Nope, not at this time.
All right, we will move on to Section GG, Functional Abilities and Goals. So what all is that going to look like? It includes eating, mobility, toileting hygiene, and oral hygiene. So what's the rationale? During a Medicare Part A SNF stay, residents may have self-care limitation on admission. In addition, residents may be at risk of further functional decline during their stay in the SNF. Well, I don't think that's any surprise to anybody about that rationale. So what are the steps for assessment? So in order to assess the resident's self-care, you can use direct observation, any self-reported, family-reported, or direct care staff reports. It needs to be documented during the 3-day assessment period, and that your 3 days is days 1 to day 3, starting with the start of the most recent Medicare stay. So whatever date you put in A2400B, start your day count. That is day 1. So a lot of times it's going to be the same date as your admission date or re-entry date, right? But maybe not. Maybe you're picking somebody back up onto Medicare Part A within their 30-day window. So that's the date that you put in A2400, right? So that starts your PPS time frame for this self-care count. Okay. You will complete only if it's a PPS 5-day assessment, or A310G is marked as 1, which is planned, and it's a Part A PPS discharge assessment. So you got to understand what all is included in these modalities, what they're looking for. So for eating, it is the ability to use suitable utensils to bring food to the mouth and swallow food once the meal is presented on a table or tray. It includes modified food consistencies, and it may also include finger foods. Oral hygiene is the ability to use suitable items to clean their teeth. Dentures, if applicable, is the ability to remove and replace dentures from and to the mouth and manage equipment for soaking and rinsing them. Toileting hygiene is the ability to maintain perineal hygiene, adjust their clothes before and after using the toilet, commode, bedpan, or urinal. If managing an ostomy, include wiping the opening but not managing of the equipment. Now, think about Section G, toileting. It's kind of different, right? So Section GG, toileting hygiene, it does not include how they transfer on and off the toilet, correct? It is just how they maintain their perineal hygiene, adjust their clothes, before and after. Okay? So that's why it's important to understand what these differences are. So some further steps for assessment. You will allow adaptive assistive equipment as indicated for that resident. The biggest difference between Section GG and G is the coding. You will be coding Section GG based on usual performance or their baseline performance. It's not going to be their worst. It's not going to be their best. It's their usual performance during this 3-day observation time. So the codes, again, they are totally different than Section G. So a code of a 6 is independent. Now the meaning is the same to me, okay, for independent, as Section G. You don't have to do anything for that resident, all right? They can do that activity all by themselves without any help, right? But the code of a 6 is totally opposite, right, than what we're used to. It's starting at the top of the list. Independent for us is a 0, right, in Section G. Now for GG, it's a 0-6. Setup or cleanup assistance is a code of a 5. And that means that, again, if a helper sets up or cleans up, but the resident completes the activity. So all you have to do is set them up. So you just have to set up the toothbrush. But then they can brush their teeth. Okay? A code of 4, supervision or touching assistance, is if the helper provides verbal cues or touching, steadying assistance as the resident completes the activity. Again, the assistance may be provided throughout the activity or intermittently, and it may be due to physical or cognitive issues or concerns. A code of a 3 is for partial moderate assistance, and that is if the helper does less than half the effort. So now instead of weight-bearing support between limited and extensive assistance, right, of what we're used to in Section G. Now for Section GG, we're talking about less than half or more than half. Because the definition is helper lifts, holds, or supports trunk or limbs, but provides less than half the effort. So again, in Section G, when we were talking about extensive assistance, as soon as we said that we helped lift, then that's an automatic extensive assistance, right? But now for Section GG, we got to know how much of the activity did the resident perform. Was it less than half or more than half? Because if it's more than half, now it's going to be a code of a 2 for substantial maximal assistance. A code of a 1 is dependent. So again, if the helper had to do all of the effort, okay, the resident does none of the effort to complete the activity, or the assistance of 2 or more helpers is required for the resident to complete the activity. So as soon as 2 people are assisting the resident with that activity, it is an automatic dependent. No matter how much of the activity the resident may complete, but if it takes 2 helpers, it is an automatic dependent. And their rationale for that, because remember, this is all about discharge performance. Okay, what's going to be the burden on the resident or caretakers upon discharge? So if it's taking 2 helpers to help that resident complete an activity, it's more of a burden on those caretakers. So that's what they're looking at. Additional codes is for a 7 for resident refused. So again, that very well might happen. You might have a resident that just totally refuses to complete the activity. A code of 9 is not applicable. So that is if the resident did not perform this activity prior to the current illness, exacerbation, or injury. So if they haven't completed it ever or for a very extended period of time prior to this current illness, then you can code it as a 9. A code of an 8-8 is not attempted due to medical condition or safety concerns. And I can see where we're going to be using that code quite a bit. Maybe not for section, the self-care items, but when we go into the mobility, I think you'll see where this code, you're going to be coding initially at first, all right? Because it is if the activity was not attempted due to medical condition or safety concerns. So coding tips. So if self-care is completed on that 5-day PPS assessment, so for the admission assessment, code the resident's functional status based on the assessment completed soon after admission, but within 3 calendar days. And this should occur prior to the start of therapeutic intervention in order to capture true admission baseline status. And this is what they just, in the final version of the REI manual, this is one of the coding tips that they just added. So then self-care completed on a Part A discharge assessment, if the type of discharge is planned. So for the discharge assessment, code the resident's functional status based on an assessment that occurs as close to the time of the resident's discharge as possible, but within the last 3 calendar days of the resident's stay. Do not code the staff's assessment of the resident's potential capability to perform the activity. If the resident does not attempt activity and a helper does not complete the activity for a resident, you're going to be coding one of those 3 codes, all right, as to why it was not attempted, whether they refused or it was not applicable for that resident to perform that activity, or they were not able to attempt to do that activity due to medical condition or safety concern. So it's important to know those 3 codes also. Ask probing questions to staff to better understand residents' performance of the activity, and we'll go into a scenario for that. This is why it's important to understand those 3 codes as to why an activity was not performed. Because even though dashes, the computer software is going to allow you to put dashes in to these self-care items, of which it means the same as what it does now, no information. However, CMS states they expect this to be a rare occurrence where we're using dashes for these items. Therefore, it may result in a 2% reduction in the annual payment update. Because they're saying, we gave you 3 codes that should fit into most situations. Why that activity was not attempted. Documentation in the medical record is used to support assessment coding of Section GG. It should be consistent with the clinical assessment documentation in the resident's medical record, can be conducted by appropriate healthcare personnel as defined by your facility policy and your state, and then the federal regulations. So we're going to go into some examples. So Mr. M has upper extremity weakness and fine motor impairments. OT places an adaptive device onto Mr. M's hand that supports the eating utensil within his hand. At the start of each meal, Mr. M can bring food to his mouth, but Mr. M then tires and the CNA feeds him more than half of each meal. So coding in this one would be coded as a 2 for substantial maximal assistance, because the helper provided more than half of that activity. Well, it's great that the scenario says that, right? But think about what type of documentation do you have to support how much of that activity the resident was able to complete. Okay. Another example, Mr. R is unable to eat by mouth due to his medical condition. He receives nutrition through a G-tube, which is administered by a nurse. How do you think you're going to code eating? So on this one, eating is an 8-8, not attempted due to medical condition or safety concerns, because assistance with the G-tube feeding is not considered when coding the item of eating. Remember, it's just how they can use utensils to bring the food to their mouth. It's not talking about their overall nutrition. Mr. F is fed all meals by the CNA because Mr. F has severe arm weakness and he is unable to assist. So, pretty easy one. This one is going to be coded as a 1 for dependent because the resident did not contribute any effort towards that activity. Before bedtime, the nurse provides steadying assistance to Mr. F as he walks to the bathroom. The nurse applies toothpaste onto Mr. S's toothbrush. Mr. S then brushes his teeth at the sink in the bathroom without physical assistance or supervision. Once Mr. S is done brushing his teeth and washing his hands and face, the nurse returns to provide steadying assistance as the resident walks back to his bed. How would you code oral hygiene? It's going to be coded as a 5 for setup or cleanup assistance, because you do not consider the assistance provided to get to and from the bathroom to score that oral hygiene. Okay, it is just the act of brushing teeth or taking care of their dentures. At night, the CNA provides Mrs. K water and toothpaste to clean her dentures. Mrs. K cleans her upper denture plate. Mrs. K then cleans half of her lower denture plate, but states she is tired and unable to finish cleaning her lower denture plate. The CNA finishes cleaning the lower denture plate, and Mrs. K replaces the dentures in her mouth. How would you code oral hygiene? It's going to be coded as a 3 for partial moderate assistance because the helper provided less than half the effort to complete oral hygiene. Mr. G has Parkinson's disease, resulting in tremors and incoordination. The CNA retrieves all oral hygiene items from Mr. G and applies toothpaste to his toothbrush. Mr. G requires assistance to guide the toothbrush into his mouth and to steady his elbow while he brushes his teeth. Mr. G usually starts toothbrushing, and the CNA usually completes the activity by performing more than half of this activity. So again, kind of tells you in this scenario, think about your documentation and what you might have to be finding out. Oral hygiene is going to be coded as a 2 for substantial maximal assistance because the helper provided more than half the effort. Mrs. P has urinary urgency. As soon as she gets in the bathroom, she asks the CNA to lift her gown and pull down her underwear due to her balance problems. After voiding, Mrs. P wipes herself and pulls her underwear back up. So in this situation, toileting hygiene is going to be coded as a 3 for partial moderate assistance because the helper provided more than touching assistance. The resident performs more than half the effort. The helper does less than half. The resident completes 2 of the 3 toileting hygiene tasks. So you can kind of see how you will have to break it down into the different tasks of that activity. Mr. J is morbidly obese and has a diagnosis of debility. He requests the use of a bedpan when voiding or having bowel movements and requires 2 CNAs to pull down his pants and underwear and mobilize him onto and off the bedpan. Mr. J is unable to complete any of his perineal perianal hygiene. Both CNAs help Mr. J pull up his underwear and pants. So for toileting and hygiene, he's going to be coded as dependent. Not only did he not really assist in any way, but it's an automatic dependent, remember, because it took 2 assistants, 2 helpers was needed to complete that activity. So it is an automatic dependent no matter how much that resident may have assisted. So what I was talking about with having to get more information than what we typically might see in our documentation. You got to do probing questions. So the nurse asks, does Mrs. K help brush her teeth? What are you typically going to see from the CNA? She can help clean her teeth. Well, is that giving you the information that you need? No, it's not telling you how much assistance that she needs. So how much help does she need to brush her teeth? Now the CNA, she usually gets tired after starting to brush her teeth, and I have to brush most of her teeth. So now you have enough information to base that you're coding on, okay? So for oral hygiene, you're going to be coding it as a 2 for substantial maximal assistance because the helper provides more than half the effort to complete Mrs. K's oral hygiene. All right. Now we're going to talk about discharge goal because you have 2 columns in section GG. You are going to be using the same 6-point scale as you did on their usual performance, okay, for the self-care items. However, you will not be using the codes of a 7, 9, or 8, 8. In this situation, you are allowed to use a dash to indicate the specific item does not have a goal, because maybe they don't. All right? So using a dash in this situation is allowed, and it will not affect that APU. Licensed clinicians can establish a resident's discharge goal at the time of admission based on the 5-day PPS assessment, discussions with the resident and family, professional judgment, and professional standard of practice. Goals should be part of the resident's care plan. Clinicians may code one goal for each self-care and mobility item in Section GG at the time of the 5-day assessment. Why is this important? Because the application of percent of long-term care hospital patients with an admission and discharge functional assessment in a care plan that addresses function is a quality measure. So therefore, you must have a minimum of one self-care or mobility goal must be coded per resident stay on that 5-day assessment. So that way, you're getting credit for this quality measure. Goals may be determined based on resident admission, functional status, prior functioning, medical conditions or comorbidities, discussions with residents and family, clinicians' consideration of expected treatments, and obviously the resident's motivation to improve. So an example of a discharge goal, because you're going to be able to code whether it's going to be higher, lower, or the same as their admission performance code. So in this situation, we're going to code it as a higher, because ultimately, majority of our residents, we expect them to improve, right? That's our overall, hope. But there are situations where it may be the same or lower, and we'll go through those. So if the clinician determines that the resident is expected to make gains in function by discharge, the code reported for discharge goal will be higher than the admission performance code. So for eating ability, Mrs. D is able to feed herself majority of her meals, but because of her fatigue issues, she requires staff to assist with feeding her 1/4 of her meal for completion. She has expressed that prior to her illness, she was living independently and has plans on going back home independently. So for her admission performance, it's going to be coded as a 3, correct? Her discharge goal is going to be coded as a independent, as a 6, because she wants to be independent. So that should be our discharge goal. So for the first column, you're going to be coding a 0-3 for admission performance. And your second column for discharge goal is going to be a 6 for independent. So it is an example for the same. So our admission performance code is the same as our discharge goal. So if the clinician determines that the resident is not expected to progress in function by discharge, but the resident would be able to maintain her admission functional performance level, this has been discussed with the resident and family, and they agree with the goal. So Mrs. E requires verbal cues, lifting and supporting of her arm to brush her teeth due to severe arthritis, Parkinson's disease. Due to her progressive and degenerative condition, the clinicians and residents feel that maintaining her function at the same level is desirable and achievable as a discharge goal. So on this one, her admission is going to be coded as a 2 for substantial maximal assistance, and then her discharge goal is going to be the same because we're wanting to maintain her functioning. A discharge goal code is lower than the admission performance code. So the clinician determines that a resident with a progressive neurologic condition is expected to rapidly decline and that skilled therapy services may slow the decline or function. So Mrs. T has a progressive neurological illness that affects her strength, coordination, and endurance. She prefers to use a bedside commode rather than incontinence undergarments for as long as she can. The CNA currently supports her while she is standing so that she can release her hand from the grab bar and pull down her underwear before sitting onto the commode. When voiding is completed, she wipes her perineal area, then requires helper to support her trunk while she pulls up her underwear. By discharge, it is expected that she will need more than half the effort for toileting hygiene. So in this situation, her admission performance is going to be coded as a 3, and her discharge goal is going to be a 2 for substantial maximal assistance, because due to her expected decline. All right, mobility.
Debbie?
Is our next. Yes?
We just got a question. Question is, so for example, if you choose eating for your discharge goal, what do you code under toileting and mobility for discharge goals on the MDS?
You can do a goal for all of them, or you can just do a goal for eating, and the other discharge goals will be a dash.
Great, thank you.
A dash is appropriate to use. Good question. All right, mobility. Their rationale, again, residents in a Medicare Part A SNF stay may have mobility limitations on admission. In addition, residents may be at risk of further functional decline during their stay. So, same steps for assessment, all right, for mobility as it was for your self-care. You can base it on direct observation, resident self-reporting, clinicians report, care staff, or family. Again, it must be documented during the 3-day assessment period, which is days 1 to 3, again, starting with that start of the most recent Medicare stay. Residents should be allowed to perform activities as independently as possible, again, so long as they're safe. If helper assistance is required due to unsafe or poor quality, you're going to score according to the amount of assistance that is provided. Again, they can use assistive devices as needed. Okay. Report usual status of ability, again, not the most independent or dependent episode. It's their usual performance. So it's the same item coding as before, as Section G's. It's not a different coding, numerical, or definition. It is the same. Independent is they can do it all themselves. 5 is set up or clean up assistance. Okay, they can do the activity themselves. Okay. A code of 4 is supervision or touching assistance. Again, it can be provided throughout the activity or intermittently. Code of a 3, that partial moderate assistance if the helper does less than half the effort. A 2 for substantial maximal assistance if the helper does more than half the effort. And a code of 1 for dependent. Again, if the helper has to do it all, or it takes 2 or more helpers. Those same 3 items for a code of 7, resident refused. Code of 9, not applicable, due to the resident did not perform this activity prior to the current illness, exacerbation, or injury. And a code of 8, not attempted due to medical condition or safety concerns. So again, you can kind of see how you might be using some of these codes more so under mobility. So coding tips. On the Part A PPS discharge assessment, The mobility items in GG 170 are completed only if that type of discharge is planned. You have to understand the definition of each activity, and we'll go through those. So just like with walking, you have to know that it's walking 50 feet with 2 turns. On the 5-day assessment, code the usual performance and discharge goals using a 6-point scale. Again, you're coding their usual performance, not their best or their worst. And you are also not coding for what staff's assessment of that resident's potential is. If the resident does not attempt activity or helper does not complete the activity for a resident, code the reason the activity was not attempted. Remember those 3 codes. If 2 or more helpers are required to complete the activity, it's a 1. We talked about that. Again, you may have to ask probing questions. Dashes, again, computer software will probably allow you to put dashes in this section. However, CMS expects this to be a rare occurrence, and if used for these items, it may result in a 2% reduction in the annual payment update. Again, you have those 3 codes. So what are you going to be assessing? You're going to be looking at sit to lying, which is the ability to move from sitting on side of the bed to lying flat on the bed. Lying to sitting on side of bed. So how can their ability to safely move from a lying on the back to sitting on the side of the bed with the feet flat on the floor and with no back support. Sit to stand, ability to safely come to a standing position from sitting in a chair or on the side of the bed. Chair bed to chair transfer is ability to safely transfer to and from a bed to a chair or wheelchair. And then toilet transfer, ability to safely get on and off a toilet or commode. So you're going to be asking these questions. First of all, does the resident walk? If it's yes, you just continue on and you're going to do further assessment. If it's a no, you got to kind of go into a little bit more detail. Is it no and walking goal is not clinically indicated? So they don't currently walk and they didn't before, or we do not anticipate them to be walking. So if it's that, then you're going to skip to GG 170. Q. Do they use a wheelchair or scooter? However, if it's no, because they're not walking now, but our walking goal is clinically indicated. We expect them to be able to walk. So now you're going to code the resident's discharge goal. So your next step is walk 50 feet with 2 turns. So one standing, can they walk 50 feet and make 2 turns? And per CMS, a turn is defined as 90 degrees or more. It can be in the same direction for both of those turns or different directions. Next step, walk 150 feet. So one standing, can they walk at least 150 feet in a corridor or similar space? This is without turns. So you assess walking 50 feet with turns, and then you assess walking 150 feet with no turns. And kind of think about your situations. What about if they don't have endurance? Maybe they can assess walk 50 feet with 2 turns, but they can't walk 150 feet, okay, because of endurance. So think about those other codes that you may be using. Does the resident use a wheelchair or scooter? If it's a no, then you skip to the self-care discharge item. If it's yes, you continue on. Can they wheel 50 feet with 2 turns? So now, once they're seated in a wheelchair or scooter, can they wheel at least 50 feet and make those 2 turns? Again, it's 90 degrees or greater. Same direction, they can pretty much do a 360 and you're good, all right? Or they could turn down one hallway and immediately within 50 feet make another turn, okay? As long as it's 90 degrees. You're going to indicate what type of wheelchair or scooter that they use. Is it manual or is it motorized? Then you answer, can they wheel 150 feet? Again, just like walking, it is without turns. And then is it, what type do they use? Is it manual or a motorized wheelchair? So example, Mrs. F requires assistance from a helper to get from a sitting position to lying flat on the bed because of post-surgical open reduction, internal fixation, healing fractures of her right hip and left and right wrist. The helper cradles and supports her trunk and right leg to transition Mrs. F from a sitting at the side of the bed to lying flat on the bed. Mrs. F assists herself in a small amount by bending her elbows and left leg while pushing her elbows and left foot into the mattress, only to straighten her trunk while transitioning into a lying position. So in this situation, she's going to be coded as a 2 for substantial maximal assistance because the helper had to provide more than half of the effort. Mrs. P is recovering from Guillain-Barré syndrome with residual lower body weakness. The helper steadies Mrs. P's trunk as she gets to a fully upright sitting position on the bed and lifts each leg toward the edge of the bed. Mrs. P then scoots toward the edge of the bed and places both feet flat on the floor. Mrs. P completes most of the effort to get from a lying to sitting on the side of the bed. So for her, you're going to be coding that for lying to sitting on the side of the bed as a 3 for partial moderate assistance because the helper provided lifting assistance in less than half the effort. Mr. F's medical conditions include morbid obesity, diabetes mellitus, and sepsis, and he recently underwent bilateral AKAs. Mr. F requires full assistance with transfers from the bed to the wheelchair using a lift device. 2 helpers are required for safety when using the device to transfer Mr. F from the bed to wheelchair. Mr. F is unable to assist in the transfer from his bed to the wheelchair. So chair to bed to chair transfer, or chair bed to chair transfer, is going to be coded as a 1 for dependent. Kind of a twofold item. Okay, yes, he did not perform any activity, part of it, right? So that's dependent. But what's the other reason why this would be coded as dependent? And that's because it took 2 helpers. So it's an automatic dependent. Even if the resident might have done part of that activity, but because it took 2 helpers, it would automatically be a dependent code. Mr. T walks 50 feet with the therapist providing trunk support and the therapy assistant providing supervision. Mr. T walks 50 feet with 2 turns. So how would you walk 50 feet with 2 turns? It's going to be coded again as dependent. And you're like, what? The resident's walking. Well, it's because of those 2 helpers. So it's an automatic dependent. So that one kind of throws you a little bit. So, but keep in mind, it's that 2-person assist. So they're going to be coded as dependent. Once seated in the manual wheelchair, Ms. R wheels about 10 feet, then asks the helper to push the wheelchair an additional 40 feet into her room and her bathroom. So for this, for a wheel 50 feet with 2 turns, it's going to be coded as a 2 for substantial maximal assistance because the helper provided more than half of that effort. Actually, she completed more than half, right? So again, some probing conversation. So the nurse states, I understand that Mrs. M usually uses a wheelchair to get to her toilet. Please describe how Mrs. M moves from a wheelchair to the toilet. How does she move from sitting in a wheelchair to sitting on the toilet? So the CNA says, it is hard for her, but she does it with my help. Well, again, is that giving you what you need? No. So can you describe the amount of help in more detail? I have to give her a bit of a lift using a gait belt to get her to stand and then remind her to reach for the toilet grab bar while she pivots to the toilet. Sometimes I have to remind her to take a step while she pivots to and from the toilet, but she does most of the effort herself. Now, again, think about your type of documentation, how your CNAs will typically respond to you when you ask certain questions, and how you might have to use these probing questions. So for this occurrence, this person is going to be coded as a 3 for that toilet transfer, because the helper provides less than half of that effort.
Debbie.
All right.
A couple questions.
Yes.
Okay. If the resident is planning to discharge on a Tuesday and the resident ends up discharging on a Sunday, is that an unplanned discharge?
It's going to be considered a planned. Again, unplanned and planned discharges is not changing. You have to code that now, okay? You have to say whether it's planned or unplanned. So that criteria is not changing.
Wonderful. Is there an advantage or a disadvantage to setting more than one goal?
Well, no, it would just be a better care plan, would be the advantage.
Okay.
So is there a disadvantage? If you're only setting one, are you really doing an accurate discharge planning? And that could be looked at in that aspect too.
Okay. Last question that I have so far is, in terms of usual performance, if someone is assistive 1 during the day with a gait belt for transfers but uses the easy stand in the evening, both is their usual performance, would you choose the most dependent of the two?
Excellent question. I guess you'd have to, again, with the easy stand, how much of the effort is the resident doing? Because they still have to bear weight, correct? And if you're not using 2, then it's not dependent. You're not using 2 helpers with an easy stand typically. So assistive 1 during the day, again, you can't base it off of that assistance of 1. You got to look at how much of that effort did the resident do. Was it half or less than half or more than half? So I would say for the easy stand, it's going to be the helper had to complete more than half because the machine is doing more than half of that effort. But you'd have to look at that daytime when they're not using that easy stand. Okay. So, and might need some further probing questions regarding that.
Okay, one more question.
But if it's being used, yeah, that one's kind of a, I'm really thinking through that one because, again, in that 3-day time frame, you got to look at their usual. So every day, what are they doing? Is it equal amongst them? Then I would go probably with the most dependent, I guess. But if it's during the day, maybe they need the easy stand on some days during the daytime and also at night. So All right?
Okay. Cues to complete a task are not considered when coding mobility at this point. And so their question is it just the physical component that's being assessed now for this section?
Say that again, Stephanie.
The cues to complete a task are not considered when coding mobility. So it's just the physical component that's being assessed?
Correct.
Another question is, what happens to reimbursement for unmet goals?
There is no impact on reimbursement for unmet goals. The only impact it will have on any type of reimbursement is that 2% reduction in the APU if dashes are used inappropriately. Now, it may have an effect on your quality measures and outcome reporting. If you say that they're going to be independent for the discharge goal and they only make it to, less than half assistance.
Okay, thank you.
Okay. So quality measures. We kind of talked about this one a little bit, and this is being based off of Section GG, the application of percent of long-term care hospital patients with an admission and discharge functional assessment and a care plan that addresses function. So your numerator is the number of Medicare Part A covered resident stays with functional assessment data for each self-care and mobility activity and at least one self-care or mobility goal. So you can see where that's pulling into your quality measure. And then your denominator is the number of Medicare Part A covered resident stays. So when a resident has an incomplete stay, collection of discharge functional status data may not be feasible. Residents with incomplete stays has an admission functional status data and at least one treatment goal would be required. Discharge functional status data would not be required to be reported. An incomplete stay is defined as those residents who with incomplete stays due to a medical emergency, who leave the SNF against medical advice, and who die while in the SNF. Because remember, what are you not doing here? So you did your admission your 5-day, right? And so you did your admission self-care items in Section GG. But you're not doing, in these situations for an incomplete stay, you are not having to do the Medicare Part A PPS discharge assessment, okay? Because it's not a planned discharge, it is an unplanned. All residents not meeting the criteria for incomplete stays will be considered complete stays. This measure is not risk adjusted. So the next one is application of percent of residents experiencing one or more falls with major injury, right? It's a long stay, and they just kind of clarified some things. So the number of Medicare Part A covered resident stays with one or more look-back scan assessments that indicate one or more falls that resulted in major injury. So you have J1900 is marked as 1 or 2. Your denominator is the number of Medicare Part A stays with one or more assessments that are eligible for a look-back scan, except those with exclusion. So your denominator exclusion, our resident Medicare Part A stay is excluded if none of the assessments that are included in the look-back scan have a usable response for items indicating the presence of a fall with major injury during the selected time window. So dashes are being used, okay, on all the assessments that are in that selected time window that they're looking back. it is not risk adjusted or stratified for this quality measure. So some new coding tips for this. It is important to ensure the accuracy of the level of injury resulting from a fall. Since injuries can present themselves later than the time of the fall, the assessor may need to look beyond the ARD to obtain accurate information for the complete picture of the fall that occurs in a look back of that MDS. So if you have a fall and they fell during your look back time frame and you might not know the result yet, or later on they continue to complain of pain, and so they re-x-ray and now it shows a fracture. So was it related to that fall? So then you might need to go back into the MDS and actually code it as a major injury or fall with major injury, all right, because it was related to the fall. That's what they're talking about. Okay. If the level of injury directly related to a fall that occurred during the look-back period is identified after the ARD and is at a different injury level than what was originally coded on an assessment that was submitted to the QIS, I forgot to change that one, ASAP, okay, the assessment must be modified to update the level of injury that occurred with that fall. So you got to go correct that MDS, okay? Then their other caution is that if you're doing that, you may want to look, does this indicate a need for significant correction of prior assessment? Was there enough information and you based everything off of that, your care plan, based it all off of that, not having that injury coded on that assessment? So is it a significant correction of prior assessment? The next one is percent of patients or residents with pressure ulcers that are new or worsened. Again, this is not a different QM. It's not an additional QM, all right? But they clarified or changed the item that they're looking at for this quality measure. So the numerator is the number of complete Medicare Part A stays that end during the selected time window with one or more new or worsened stage 2 to 4 pressure ulcers at the end of the stay. This is determined by the following conditions on the target assessment, again, which may be a Part A PPS discharge or OBRA discharge assessment. So, has a stage 2, 3, or 4, has it worsened? Okay, that's what they're looking at, is that item. Okay, they were looking at a different item on the MDS before. Now they're using M300, B, C, and D. Your denominator is all complete Medicare Part A stays in the selected time window for SNF residents ending during the selected time window, except those who meet the exclusion criteria. So in the REI, they have updated some of the steps to determine present on admission. And they added, if a resident who has a pressure ulcer that was present on admission, so it was not acquired in a facility, is hospitalized and returns with that pressure ulcer at the same numerical stage, the pressure ulcer is still coded as present on admission because it was originally acquired outside the facility and has not changed in stage. Okay, so they came in with a stage 2, and they go out to the hospital with that stage 2, and they come back. Okay, then it's still present on admission, as long as it's still the same. Okay, what happens if it's worse when they come back? Then it's present on admission. Okay, what if it was you had a stage 2 acquired in your facility and they go out to the hospital? They come back. It's now a stage 3. Is it acquired or not acquired? In that situation, it is not acquired, so therefore you're going to be marking it as present on admission because it worsened in the hospital. This slide, it just shows you the steps. So under step 2, basically they just kind of removed it and made most of it a separate step, okay? And then they added 6. So we're trying to get ready for October 1st, trying to do some research and that kind of stuff. Came across some questions that were pretty interesting to me and I thought were helpful. And they're coming from ANAC, and they come from master clinicians on ANAC. The answers do. So the first question is, I am reading through the draft manual and see we can combine the Part A PPS discharge with the OBRA plan discharge assessment. I see the ARD has to be the actual discharge date, but when combined, what are the 3 days for the GG look back for functional status at discharge? Okay, that's basically what her question is. Kind of gets a little bit confusing when you read more of it. So the answer is, according to the draft manual, and it goes for the final also, the look back for the PPS Part A discharge would be the last 3 days of the Medicare A2400C date and the 2 days right before. So you're not basing it off the actual ARD if you're combining it with the discharge assessment, an OBRA discharge assessment. It must be the date that you code in A2400C as the Medicare last covered day. The next question, we have a SNF inside our hospital, so a lot of our patients leave as unplanned discharges. So for example, if a Part A resident admits on 10/12 and then discharges on 10/13, he did not stay 3 days to do Section GG. Do I just continue with regular 5-day admission assessment, or do I still complete the Section GG items? Answer. The detailed instructions about this are on page GG2 and GG14 in the RAI manual, where GG is pictured. At the top it says, complete only if A310G is not equal to 2 and A310H equals 1, and A2400C minus A2400B is greater than 2, and A2100 is not equal to 3. Well, that's clear as mud, right? So I love this response. The translation. Complete only on planned discharges and when it is a Part A PPS discharge. The Part A stay was at least 3 days and the discharge was not to the acute hospital. Last question. I am trying to find information about when it is acceptable to do my narrative note regarding admission documentation for Section GG. Are we to do our assessment notes on day 3, or do we complete our observation through day 3 and enter our assessment finding notes on day 4? I have been reading whatever information I can find out, but I haven't found anything stating what the expectation is for when we enter our narrative notes. If day 3 is on Saturday or Sunday, is it okay to do the narrative notes on Monday for the weekend? I want to do the right thing. Answer. You will not find any regulations about the documentation to support GG other than what's in the REI User's Manual regarding documentation to support the MDS in general. It does say that it needs to be documented. It does not say how it needs to be documented. Okay? There's no requirement for a narrative note. It's however you choose to do your documentation. Okay? So this responder states, I would say first that the important point is that any auditor, including surveyors, should be able to come to the same coding decision entered in GG through a reading of the overall chart that's the same as it is for the rest of the MDS. How a facility will achieve this depends on how the facility decides to collect GG information that leads to the coding decision and how those GG coding decisions are documented in the record. So you can use flow sheets combined with Q-shift staff interventions or other methods. And I will leave that up to Stephanie. That these are references that were used. And I'm going to turn it over to Stephanie. First of all, are there any questions, further questions, Stephanie, at this time?
Not yet. So I'll go ahead and do my part.
Okay.
And we'll come back together at the end.
All right.
Right. Okay, so you should be seeing my presentation now, which starts with a slide of process. So if that's not happening, certainly let me know. So some of the changes that are going to happen for us in change of this process is making sure we do have daily reimbursement meetings. There is also a daily reimbursement meeting sheet that I've created with some help from others. I've kind of taken one that ended up being already set up. The first part of this page, or the first page of this document, is something that you should already be addressing in your reimbursement meetings. So I'm going to go ahead and scroll down a little bit further, and the new additions start on page 2. So for all new admissions that are Medicare A resident stays only, on day 1, nursing would be initiating the admission assessment, observing and documenting self-care and mobility performance, and notifying therapy of any orders that they have for them. Therapy would be screening Medicare A residents on admission if there are no orders, and then they would be evaluating and possibly treating if there is an actual order for therapy. On day 1, social services should be completing the family interview for prior level of function and what the expectations are for discharge. On day 2, we're going to review the information that we gleaned from day 1's documentation. Nursing should be running a point of care documentation report and bringing that to the meeting so we can observe the documentation for the self-care and mobility that the CNAs have already been documenting. Therapy would eval and treat based on when orders were received, and they would report any findings they have. And then social services, if they were not able to get that information on day 1, would definitely be making sure we get that information for day 2. On day 3, we were going to review day 2's documentation and compile that with day 1. Nursing, again, will bring that same information as well as therapy. And then on day 4, this is kind of your pull it all together day. So we discuss all 3 days worth of documentation. Nursing presents on the self-care. Therapy will provide any other insights. Therapy would present on the mobility scores if they're treating them, and nursing would provide insight for what they're seeing. And then the MDS coordinator is going to make sure that all of that documentation is reviewed at your meetings, and the team will determine the usual score for each item. At that time, you'll also decide on an appropriate goal, which BHS is recommending at least 1 goal, not saying you have to have 5 goals, but that's going to be up to you. But we are requiring at least 1 goal. And then we would go ahead and have a IDT progress note entered by the MDS coordinator to show what the decision that was made. MDS Section GG would then be filled out when you open up your MDS on day 7. Number 9 is all Medicare A residents. We want to make sure we're monitoring them daily for discharges. We know that discharges can happen quickly, but we want to make sure that we're trying to get all of the documentation in line and know if someone's saying they're going to leave on Wednesday instead of their planned discharge date of Friday, so that we can keep therapy monitored in there. The other thing that we're going to do is make sure that point of care documentation for all Medicare A residents, that section for GG that the CNAs are going to be filling out, will be open for the entire Medicare A stay. Number 10, all discharging residents for Medicare A stay only. In the last 72 hours, nursing needs to be pulling that point of care documentation report, bringing it to the meeting, and the team should be reviewing that documentation for usual performance. Again, in the last 48 hours of their Medicare A stay, nursing will bring that documentation and talk about it. The team will review, initiate discharge assessments, and review current status to determine if that is usual function. Therapy will bring their information and present it at the meeting for team collaboration. In the last 24 hours of a Medicare A stay, nursing will present the self-care scores. Therapy will provide insight, complete any discharge assessments that are needed. Therapy will present the mobility scores if they're still being treated. Nursing will provide insight, and therapy will complete their discharge documentation. The MDS coordinator will consolidate all this information found during the observation period and collaborate with the team to determine their final scores and usual performance to make sure that their goal was achieved, and you will decide that as a team. At that time, the Medicare coordinator will complete an IDT progress note to reflect all of the information and then complete the MDS Section GG for discharge. So now I'm going to pull back up my presentation. And Debbie really did a nice job going through some examples and some documentation. So I just threw a few more things on the end of the presentation just to show you how we should be thinking about the usual performance. And then some sample notes. So on this section, GG was completed today based on chart review, direct observation, and discussion with the direct care staff, patient, and family over the observation period. The following are usual performance for self-care and mobility. Partial to moderate assistance of 1 for eating, partial and moderate assistance of 1 for oral hygiene, substantial maximal assistance of 2 for sit to lying, substantial maximal assistance for 2 for lying to sitting on the side of the bed, dependent for sit to stand, dependent for chair or bed to chair transfer, and dependent for toileting transfers. Again, Debbie addressed this with the not assessed, but there are 3 reasons we would have not assessed used, and that's because either the patient refused, we didn't do it because of medical or safety reasons, or it was not assessed because they're not applicable. Again, there needs to be an IDT note addressing those issues as well. So this is an example of that. So the patient is sort of short of breath on exertion with their recent discharge from an acute setting due to an exacerbation of congestive heart failure complicated with diabetes. The following items were not assessed due to the unstable medical condition. Walk 50 feet with 2 turns, walk 150 feet, wheel 250 feet with 2 turns, or wheel 150 feet. These are some examples of what your note could start out with for your goal. So if we expected the resident to improve, you can use the one on the right. The resident is not expected to improve, you can use that one. And then expected to decline is that's how you would start your goal. The IDT team, this is a sample goal note. The IDT team has determined that as the CHF stabilizes, the resident is expected to make gains in function by discharge in the following areas. Increase to supervision or touching assistance as the usual performance for eating. Increase to partial or moderate assistance as the usual performance for sit to stand. Increase to partial and moderate assistance as the usual performance for chair or bed to chair transfer. Increase to partial or moderate assistance as the usual performance for toileting transfers. So next steps. Start practicing holding the daily reimbursement meetings and start discussing the self-care area and goals for admissions and all discharging residents. Now that being said, the question came up yesterday. It is not the expectation that you will be having reimbursement meetings on weekends and holidays. However, the data still needs to be gotten from the residents and still needs to be addressed that next day when you return to work. A recorded version of the presentation will be available for training for those who are not able to attend, and an email will follow next week with the information after the webinars are both completed with some frequently asked questions. There will be a point of care PowerPoint presentation sent out to the RAI coordinators in the next 2 weeks for the training of the nurse aides during the last 2 weeks in September for the documentation that they need to have, since it is different from what they're currently coding in G. We did decide as a group that it's important for the CNAs to continue to document on the work that they do. So that's why we're going to have that section GG open for all Medicare Part A stays for their entirety for the documentation. Therapy will be having further webinars for their staff. MDS coordinators, DONs, and administrators are welcome to attend, but just know they are specific to Kasamba and SMART. And at this time, Kasamba, SMART, and Matrix Care have not yet completed their updates for all of their software. So we still are not exactly positive what that's all going to look like. So there is more to come. Just make sure that you're prepared. We also will be having a breakout session at the Leadership Conference in Duluth to go into more information. So now I'm going to open it back up and we'll see if there are any other questions. The only question I see so far is, were the slides sent out? Yes, I sent all of the slides out to the same people who got the meeting request yesterday, somewhere between 12 and 12:30. They are also available, if you didn't hear the first part, in the handout section. There are 3 handouts in there. So the MDS updates PowerPoint, the daily reimbursement meeting, and the Medicare meeting format. So those are available now. Again, I'll be sending them out next week as well. Any other questions you have while we have Debbie's ear? Remember, you need to type them into the chat box if you have other questions.
Stephanie, I would like to re-clarify. I was able to read one of the questions.
Yes.
And I think I had a misinterpretation of what was said. It was about the mobility, about queuing. I don't know if you want to reread that question.
So the cues to complete the task are not considered when coding mobility. It's just the physical component that's assessed.
Yeah, and I think I answered no, but yeah, queuing is part of it. It is a code. So they will be coding towards that because you're using the same codes as before. So it's going to be a code of a 4 for supervision or touching, okay? Because if the helper provides verbal cues, then it's a 4. And that includes 4 mobility items.
All right, any other questions? All right, seeing none, I'm going to say have a great holiday weekend. Please be safe out there, and thanks for attending.
Bye, thank you.
Bye, thank you.